We're going to go ahead and get started. Welcome, everyone. Andra, if you'll kind of keep track on the admission side for the waiting room, that'd be great. Thank you so much. Well, welcome everyone to our webinar today, which is using qualitative feedback to adapt a nursing communication simulation for nursing students and novice nurses. We have a team of faculty and nurses from University of Connecticut, and I'm going to let them introduce themselves because they know who they are. So we're thrilled to have them with us today. And just so individuals know, after this webinar in the next week or so, we will send everyone who attends a link to the recording as well as to the slide deck. So you will have that available to you after this webinar. It also is all posted on our LMEC Faculty Corner website for later use. And also, just briefly, I'm Dr. Megan Lippy and Dr. Andrew Davis is here. We are the co-investigators with LMEC that support schools of nursing. So we're thrilled to have you. And with that, I'm going to turn it over to our fantastic presenters today.
Great. Thank you so much, Dr. Lippy. So I just wanted to introduce myself, and my colleagues will introduce themselves when they are up to present. So my name is Amisha Parekh Campos. I'm an assistant clinical professor at the University of Connecticut. And what we did is collaborate among academic and clinical settings. So this was a great opportunity for all of us to work together to try to bridge that academic and clinical partisan, just to make sure that what we do in our curriculum actually translates and it translates well. So simulation-based education, it's a pedagogy that can be used in many settings. So this was an ideal setup where we could bring in an existing simulation and apply it to an academic student community and a clinician RN practice. Next slide. Before I go on, I just wanted to mention that we have a colleague, Dr. Valorie MacKenna, who cannot be here today. She had a family emergency, but I will be, covering her part of the presentation. So first, I wanted to give a little bit of background. As we all know, there's a lack of training in palliative care in all aspects of nursing, including schooling in both the undergraduate and graduate levels. There's a lot of literature out there on that nursing students are not prepared or feel comfortable working with patients in palliative care. This is also true when it comes to professional development and practice. So those who are practicing RNs, especially our novice nurses, aren't, again, very comfortable because they haven't had the chance to experience working with palliative patients and having conversations with them. And we do know that palliative care is essential for patients of all ages and all stages of disease. So one of the most effective ways to understand palliative care is through simulation-based education. There's often a lack of exposure to palliative care in the clinical setting, and having difficult conversations can be daunting to a student or even to a novice nurse. So simulation-based education is a way to practice these conversations in a safe space. Another benefit of simulation-based education is its adaptability to be used with multiple populations, settings, with different scenarios. The literature has shown that simulation-based education significantly enhances communication skills in palliative settings, improving both verbal communication and nonverbal cues. So in this presentation, we will discuss how we used an existing simulation in advanced care planning communication and adapted it to novice nurses in a nurse residency program and pre-licensure nursing students in their 3rd and 4th year of school. Next slide. So the original simulation that we used was called Conversations Had at Trying Times, or CHAT for short. It was developed in 2020. In full disclosure, this simulation was my dissertation study when I was at the University of Connecticut. And the team that I worked with and I worked with the health system in Connecticut, Middlesex Health. And we collaborated with the team there to use this simulation on nurses that were practicing on different units in the health system. The simulation was created through the theoretical framework of the Jeffries simulation theory, which is widely used in simulation, and Albert Bandura's self-efficacy theory. The development of the simulation went through a rigorous process of content validation. And really, we try to strictly adhere to the INASCL standards, the International Nursing Association of Clinical Simulation and Learning. So we really wanted to make sure that this was something that could be redone by many other people, but also it could be adjusted and adapted. The simulation consisted of a patient with end-stage COPD, Jane, and her daughter. The patient just had a palliative care consult and was given morphine for the first time with good effect. The participants in the simulation were tasked with specific learning objectives that consisted of education about morphine, use for symptom management, discussing advanced directives, and also having advanced care planning discussion. The outcome measures that we looked at were changes in knowledge about palliative care, changes in attitudes, and changes in self-efficacy. In initial tests of the simulation among practicing RNs, it was found that years of experience significantly changed knowledge, attitudes, and self-efficacy scores positively. The younger, inexperienced nurses, their scores did change positively. However, there was definitely a significant lag compared to those experienced nurses. If you would like to find this simulation, it is located in the LNEC Faculty Corner Resources section, and this QR code right here will take you directly to all the components of the simulation. So next, we will discuss how the simulation was adapted to the pre-licensure nursing program and the nurse residency program and the outcomes of the adaptation. Next slide.
Thank you, Dr. Parekh Campos, for championing this topic for our undergrad nursing students. My name is Laura Eiss. I'm a clinical instructor at the University of Connecticut, and I'm the course lead for the Fundamentals of Nursing and the capstone courses there. It's a public university. It's an R1 research institution. For this traditional undergraduate nursing program, for phase 1 of this adaptation of this simulation, we had 153 nursing students in their junior year, their 3rd year. And then phase 2 was completed in their 4th year during their capstone course. And the 131 students that completed that phase had done phase 1. All 131 had. In the simulation, as Dr. DeCampo said, we do stick to the INASCL healthcare simulation standards of best practice here. And just for point of reference, the students in the traditional undergraduate program are exposed to some hospice and palliative care content, patient-centered care, and effective communication during their 3rd year of their fundamentals nursing course prior to completing this simulation. It's reinforced throughout those remaining semesters. And then their capstone course has some wonderful options for palliative care, hospice care, focused clinical experiences. Next slide, please. So just about the unfolding simulation. In this phase 1, this was, they did a little bit of pre-work. They reviewed an article by Whitehead et al. And answered a reflection question about how comfortable were they with this topic. Then when they came into the simulation, we did a bit of a pre-brief, talked about that a little bit, and they were given the simulation scenario. We used standardized patients, Jane and her daughter Emily, and they were given scripts and queuing options to meet the sim objectives. And then we had 2 nurses from the student group completing 2 different states during this simulation, and everyone else in the room was an observer, and they created a plus delta list that was part of the debrief. This scenario included Jane, as Dr. Parekh Campos noted, that had some deteriorating COPD. She'd been, we adapted it this way in that she'd been in the hospital a few times, kind of deteriorating, having a little bit more respiratory distress. And it seemed like it was time to maybe be having some conversations about advanced directives, code status, and advanced care planning as the goal. The student nurses were given the report. They knew the objectives of the sim, and there were some props in the room too that were kind of in line with that effective communication. Like we had a TV on, we had multiple chairs off to the side, waiting to see the students' engagement with those different props. When the scenario was completed, we debriefed using the students plus delta list that they created from their observations. We reviewed some of the feelings around this communication, as well as talking about just, we did a little bit more education on code status, advanced directives, and advanced care planning. They also answered the same post-reflection question and how they felt with comfort level after they completed the simulation. For the fourth year students, when they came back into phase 2, we reminded them that they'd met Jane before. And they all were like, oh, yes, we remember Jane. Only in this situation, they had done some pre-work on communication tools, effective communication tools. I always talk about with my students in capstone and fundamentals, I love to toolkit you. What can we put in your pocket to help you be more successful? So Dr. Parekh Campos put together a different assignment for these students in that they were to research different communication tools like the nurse acronym or the SPIKES acronym, and then decide which they would use going into the room. We also equipped the students with the Vital Tips app, which they could use as well if they wanted to, which gives them some guidance on how to engage with more challenging conversations. So they were given a report for this scenario. And in this scenario, again, we had standardized patients with Jane, and then Emily, her daughter, entered into state 2. And in state 1, Jane was a little bit more, her end-stage COPD had developed, and she was deteriorating. She had frequent hospitalizations, ICU admissions, intubations. And honestly, when the nurses entered the space, were confronted with a patient that was very angry, withdrawn, sad. Whatever it was, they needed to use those communication tools to try and pull out from Jane what was going on. And again, engage in that advanced care planning. What were Jane's goals? So this was the goal of that simulation and that scenario. The debrief for that, we went back to the resources for the RN, for the role in communication. We talked about how they felt about that space in that space. The interesting part was this scenario led into a family meeting for state 2, and that's where Emily came in. And the role of nurse as facilitator, as advocate, and as interprofessional collaborator provided a great opportunity to discuss the different roles of hospice and palliative care providers, of community resources, as well as the role of just the nurses in this space, giving room for the family to kind of come to some agreement and conversation. So it was a really interesting simulation. Dr. Parekh Campos gave us a nice video guide on how to run a family meeting because she's run a few in her life. And she gave the students quite a few great tips that they wrote down religiously, brought to the meeting, and stuck to, and they found it very beneficial. So in the debrief, we again talked about resources for this RN role in communication. They completed a post-reflection about their comfort level with engaging in these conversations. And I was interested to see how well they used those tips that Dr. Parekh Campos had given them for that family meeting, that it really helped them keep the family meeting on track, which I thought was really wonderful. Next slide, please. So in the third year, some of the student outcomes we noticed was they focused on code status and advanced directives, very fundamental knowledge, information, clearing up information for the patient as opposed to that advanced care planning. Took them a little bit of queuing. Sometimes they would get there. Some discussion of outpatient options in home care, our DPH program in the state of Connecticut, where code status is supported in the community. We did a little bit of debriefing with that. And then just again, going over some communication tools. The work of, understanding the role of morphine, that was also discussed in some of the student outcomes because there was a knowledge gap there that we found with this. In the fourth year, in that phase 2, the students, use of communication tool was varied. Some were able to take those communication tools into the space and use them effectively. That interprofessional collaboration, they found that meaningful. Understanding hospice and palliative care roles, that grew, and they felt like that really helped. Guiding a family meeting, they appreciated the tips that they'd received on how to do that and why that was so meaningful. And even just acknowledging the emotions around these kind of conversations and tips and tools for supporting patients and families. Next slide, please. Our students had some great feedback as they went through. Would you be comfortable? So this pre-simulation was, our students came up with things like, this is daunting, this is uncomfortable, it's difficult, I'm hesitant to do this. Some of the students wrote, as I write this, I'm realizing I do not know any of the information about advanced care planning. This therefore proves my point. I'm not feeling comfortable about talking about this. And one student felt fearful that patients would not accept their thoughts or suggestions. Students revealed that much of their fear of having advanced care planning conversations stem from their lack of knowledge about advanced care planning and their anxiety about the patient's reaction to the topic. In the post simulation, we did have some wonderful reflections from the students. In phase 1, I think this was good practice, many of the juniors said, because I feel better equipped to have conversations on this topic. The resources discussed would be definitely helpful as well. Another student mentioned that this simulation was helpful in learning how to approach the family in a calm manner and addressing their questions. And the phase 2 students, those senior capstone students, a student stated that she liked it when the student nurses in the simulation asked the patient's family to sit down and reinforced that their role was to answer questions and be supportive. And some students stated that they felt comfortable, they could at least initiate a conversation. I think the biggest takeaway for me of what they realized was that they knew they should prepare before having these conversations, that just taking a moment to step back and plan and prepare before they go into having those more difficult conversations was really meaningful to them. Thank you so much. I'm going to hand this off to my colleague, Lauren Boulé.
Thank you, Laura. You can go to the next slide. So as Laura just mentioned, my name is Lauren Boulé, and I am currently the clinical placement coordinator and clinical faculty at the University of Connecticut. But during the time of this project, I was the nurse residency program coordinator at Middlesex Health, which is a small community hospital in central Connecticut. The hospital has been supporting new graduates since 1999 and have gone through a series of different types of residency programs. And I had the privilege of helping run it for 12 years until moving to the University of Connecticut. The program and a little bit about the nurse residency program at the organization. It was a year-long program and we ran about 2 cohorts a year. It usually held between 10 and 20 residents per cohort. And the goal was obviously to help them transition from academia into practice and really focus on some of those key issues like end of life that were really complicated to get them feeling better and better take care of their patients. The organization is a 6-time Magnet designated hospital, as well as a 2-time ANCC PTAP accredited in the med-surg environment with distinction. And if you know anything about these distinctions and these designations, it really is a focus on best practice and outcomes and really looking into the literature to try to use the best evidence out there to give them, these residents, the best experience that they can have, as well as providing them with the education they need outside of their undergraduate programs to better take care of their patients. They also partner with the VISI and AACN nurse residency program, and I bring this up because I think it's really important to understand that the VISI and AACN nurse residency program has been studying these nurse residents for well over 20 years. They have huge amounts of data. Part of being a part of the program allows you to be integrated into their survey system, where they survey these nurses, these new graduates at initially upon hire at 6 months, 12 months, 24 months, and 36 months, which also focuses, they use the Casey Fink survey, which is a self-efficacy survey about key issues such as end-of-life care. So one of the things that we do know is, besides the fact that many new graduates will tell you they don't really understand, they're uncomfortable with the end-of-life care of patients, is that we know it because they've studied them. And that's one of the things that this program has shared with us over the years. So it shows us that they struggle with it and that they have difficulty providing that compassionate, competent care that they need to give these patients. So as the residency program coordinator, I always focused on skills and things they need kind of upfront in their residency, you know, things that they definitely needed to take care of their patients, time management, prioritization. And as the year progressed, I would then add in complicated scenarios that maybe they have experienced or not experienced, like end-of-life care, because I felt like, okay, they've got all the tools, like Laura was talking about, tools in their tool belt to take care of the patient. Now, how do we do it better and have some of these end-of-life conversations that can be, or complex conversations that may be a little bit more uncomfortable. You can go to the next slide. So our group was a little bit smaller than the undergraduate nursing students. Our nurses, we did about 28 nurse residents who completed the advanced care planning simulation. We had 2 cohorts of about 14 over 2 years. So we did obviously have fewer participants than the pre-licensure program, but we had very meaningful insights, and I would say it's very similar insights that you saw in the undergraduate program as well. So our structure, and not going into too much detail because I really feel like Laura shared a lot of what the simulations actually looked like. Our structure was a little bit different. We did utilize the Whitehead article as pre-work. So we asked all of these nurses to read the article before they came in. It is a they did have a designated day that they come to the residency. It's a classroom day that they're taken away from the floor. So we were able to have a pre-reflection and advanced care planning conversations before they got any education, kind of talked about the Whitehead article a little bit. Amisha was the facilitator for this as well. And she had the privilege to be able to go through some palliative care concepts. When you do this all the time, it rolls off your tongue like it's very powerful. And when you bring in the experts, it really is pretty powerful to these nurses to try to understand. They can ask really good questions. So bringing in those experts is key. But it was a little bit less detailed for the pre-licensure students, only because we had time constraints and we don't have them as long as the undergraduate nursing students have in their program. But we did have the phase 1 advanced care planning simulation that we utilized. So the patient had COPD. There was 2 students that went in and they were role playing with other students to have the conversation about the morphine and when it was given, and conversations. They were given a structure behind what they needed to accomplish within the simulation. And then the rest of the crew was in watching it live streamed, and then there was a debrief afterwards. And as we all know, that simulation, really a lot of the learning occurs in the debrief and the conversations that happen afterwards. Okay, you can go to the next slide. So for the pre-simulation reflection, some of the things that we gathered were that people did have exposure to advanced care planning than we kind of had expected. In the beauty of doing this more around the 9, 10, 12 month or 9 and 10 month mark of their residency program is that they've now spent that time on the floor experiencing patient questions and conversations and diagnoses and we were very lucky to have a palliative care and hospice team that does do a lot of consults, like Amisha has been doing in her career. That all was there for them to experience before they came. Some had it, some didn't, but we were able to see that they did have greater exposure to it than, say, the undergraduate nursing students. The barriers that we identified pre-simulation is that many people lack advanced care planning, that they're not set up. And one of the quotes that we had was, after working in the hospital for only a few months, it's clear that many people don't have their advanced care plans set up. So then the question became, time constraints. They talked about time constraints and having these conversations, and then the limited nurse experience. And the quotes that kind of went along with that were, being a young nurse with no advanced care planning myself, I'm not sure as to everything that is included, let alone bringing up the conversations with my patients. So same thing that you saw in the undergraduate program as well. And then another quote was, institutional barriers can include a lack of time to discuss advanced care planning with a patient. We sometimes only take care of patients for one night before they're discharged back home. So a lot of these nurses, not only are these patients, there's a push to drive patients home, not to keep them in hospitals for a long period of time. These nurses are working 12-hour shifts and sometimes don't come back for a couple of days. And so they tend not to see the same patients unless the patient's there for a long period of time. So it's hard to build that trusting relationship, especially when somebody is only seeing them for a very short period of time, and to actually have the conversation and to know what to say. So then the simulation occurred, and then post simulation, you can go to the next slide. So post simulation, one of the things that we kind of saw in the reflections was that there was an increased awareness of sensitive communication. they started to realize that they needed to have these conversations, especially with a lot of the complex medical diagnoses that these patients are receiving. And many of them are seeing these patients over and over again as they begin to come back to the hospital too. Some key skills that they kind of recognized were that they needed to create a calming environment and that they needed to ensure understanding of disease and treatment. So some quotes that kind of went along with that are that one was, I am more aware of the delicate manner in which these decisions have to be made. It allowed me to consider ways with which I can have hard to have conversations, more comfortable for both myself and patients and families. They also kind of talked about how one quote was, we discussed the time that sometimes patients' goals don't align with the goals we as nurse feel is right for them. And I think at times I struggle with this concept. So this also is a nice way to kind of introduce the whole ethic component behind a lot of these conversations as well. And you can tie a lot of that into it. And sometimes it's hard as a nurse when we feel something's right and the patient doesn't feel the same way, and tie it all into that. Another quote was, I learned how important it is to start by creating an environment for conversations to occur that's calming with no distractions. I also learned to ensure that the patient understands their disease and prognosis and the treatment they're receiving. So they walked away with good, solid tools. We also coupled this with a little bit more education post to try to get them to look at their own lives. We used the Go Wish cards to kind of tie in to show that everybody has different feelings at end of life, or what they want at the end of life, so that they can show that they need to really look at what's happening with their patient and what maybe is important to them, and be sensitive to that as well. But again, if you're lucky enough to have experts that surround you, or if you are the expert, it's really a wonderful thing to bring them in, to have them understand the key components so that they can kind of arm themselves with those tools to go out and take care of patients and guide them with these advanced care planning conversations. And I'll hand it over to Amisha.
Thanks, Lauren. The next slide, please. So clinical implications. There are a lot of reasons to implement a simulation in palliative care, whether it be communication or any other aspect of it. The first thing is, we usually tend to avoid what we don't know or what we don't feel comfortable with. And the more that nursing students or practicing RNs can learn the fundamentals of palliative care and communication, the more equipped they are to start that conversation. And this includes advocating for the patient and identifying palliative needs to either refer them to palliative care, or find other team members that can provide that palliative care support. So even if it's not them necessarily providing the palliative care, it's the recognition of possibly, okay, this is a place where a conversation, could be had, or this is a place where maybe I need to refer out, or suggest to a team member, hey, can you take a look at this patient, or have a conversation with the patient. And it really allows students to learn a little bit more about palliative care. There is a lot of misconceptions out there that palliative care and hospice are one and the same, and that palliative care means terminal care, means end of life care, even though that's not necessarily the case. Often students don't necessarily learn about goals of care. And so this really gives an opportunity for these students to really learn about what palliative care is, and the different aspects of the role as a palliative care provider. A lot of what we do is communication and conversations and goals of care, but from there we can really figure out the plan of care. And I think that's really important for students and novice nurses to know, just because that isn't something that they might be looking at holistically. So it does give them an opportunity to learn about the nurse's role, and that it isn't necessarily about someone who is actively dying or terminal or at the end of life, but more about finding out what the priorities are for someone who has a serious illness. So the simulation can allow these nurses and nursing students to practice these new skills and receive feedback without the concern that they're harming the patient or that they're doing something wrong. Palliative care conversations are one of those sensitive topics that the more experience you have, the more comfortable you are with them. And in clinical settings, nursing students or novice nurses may not have this comfort level. Next slide, please. The other thing is also recognizing that this is part of the RN scope of practice, and ensuring that nursing students realize that too. Often what I've heard from feedback from nursing students or even practicing nurses is that they are not allowed to talk about this. And it's not talking about prognosis, which a lot of them think it is. It's about talking about goals of care and different options for the patient, and just kind of planting that seed. I use that term a lot, and that seems to have stuck with a lot of the nursing students and some of the nurses that we worked with. Just having that opening for a conversation, and the simulation is really quite simple. I think when the students and the novice nurses go into it, they think it's going to be this, big, huge conversation. They have to get the patient to become a DNR. They have to do all these different tasks, but it really is just talking to them about their goals. And then they're done with their learning objectives. So it is simple in that way, but it's also complex because it is a topic that we avoid a lot in our society in general. It doesn't talk about death or planning for end of life. And so often what happens, and even as a practicing hospice nurse, I have, coworkers who have often said, oh, well, with our palliative care patients, they want to talk about their options and their goals. So let me refer social work, or let me talk to the provider about having that conversation, when it really is within our scope to have these conversations as well. And again, just these conversations happen again and again and again. It's not a one and done. So it gives opportunity for the nursing students and the novice nurses to learn that, I can start this conversation, and I still can refer social work to be involved, but let me get the ball rolling, just so the patient has some time to think about it too, because it is a lot to think about. And that way they can initiate this conversation, but they don't have to wrap it up in the bow and have everything squared away at that point. Next slide, please. So the simulation also allows practice. And I think, with the nursing students, we have the opportunity from the 3rd and 4th year to be able to use the same patient and do an unfolding simulation scenario where they get to meet the patient again, who has deteriorated even more from the last time that they saw them. So, they can go through the simulation, receive feedback, and they're not worried about harming the patient in any way. And for nurses and nursing students, communication, or these soft skills, can be really challenging. In nursing school, you learn about therapeutic communication, but specifically for those who have a serious illness, it might be a little bit more difficult to navigate. So this can, impact patients if, I remember when I first started as a floor nurse, I was scared to talk to anyone about anything, let alone, a bigger picture about, what their options were for care. And I did, looking back on it, recognize that there were a lot of patients that were very appropriate to have these conversations with, who were, elderly and going through treatment, but, they weren't really given that option of, what are your goals? What is your plan? What do you want to accomplish towards the end of your life? So, hindsight's always 2020, but having these skills, I think when I was in nursing school, would have been great. Or having just a little bit of information about it so that it can prepare me for encountering situations and recognizing that, there are other ways to navigate this situation with a patient, especially those patients. I remember I worked neurotrauma when I first came out, and I would see patients over and over and over again, and we would treat them and then discharge them. And looking back on that, I'm like, that there was so many opportunities there. So having the nurses have that option is something that we can do with, practicing this type of simulation. Another option too is that not only, the simulation that we use, the chat simulation, but there are so many other simulations out there that have interprofessional roles in it that go into more about hands-on care when it comes to end of life and palliative care, that really talk about all aspects of palliative care. And those simulations are also very adaptable to different populations and different environments. Easily I could take the interprofessional simulation, let's say, and make it into a home care setting. And I think that's a great resource and something that we should utilize, because reinventing the wheel and trying to create a whole new simulation is pretty daunting. So having the resources that we have, and in the faculty corner at ALNEC, there's a whole list of different simulations we could use, and adapting them to whatever works for your curriculum or what your needs are is a really good option. And especially now that we are going into the AACN essentials and palliative care and comfort care and hospice care and supportive care is one of the spheres. We really want to focus on trying to integrate more palliative care practical work into the curriculum. And this, for our program, would go hand in hand really well with the communication module for ALNEC. So there are a lot of resources out there, and it doesn't take up a lot of space in the curriculum necessarily. It can really enhance, some of the things that the nurses already are practicing and doing. And this is another aspect of that, just because there are other skills within this that can be used for those essentials and those competencies that these students need to have. And then the last thing we were talking about as a team is that in medical school, there's usually a course or a class or a discussion about breaking bad news. And that is about prognosis and giving someone, let's not a terminal prognosis or, a short prognosis because of their disease course. However, in nursing school, we don't really have that type of training. And we do talk about communication a lot, but when it comes to someone with a serious illness, we don't necessarily have that as one of the aspects of communication that we do need to really practice. Again, with all of the resources and the tools out there, just like Laura mentioned that she used the NURSE acronym and spikes, there are so many tools out there. The nurses and the students were introduced to Vital Talk, which is an app by R&D Labs that is great. It just, if you have a conversation coming up, you just type in what the topic is or how you want to prepare for it, and it gives you tricks and tips about how to have these conversations. Same with just a lot of the resources that are out there. One of the things I did introduce to the nursing students and to the novice nurses was advanced directives from the state of Connecticut. The Department of Public Health has advanced directives that don't need to be notarized, or, they have to be witnessed. But some of even the nurses in the nurse residency program said that they've never seen one. They've never had the opportunity, like they see in the chart that they might have a DNR status, but they've never actually seen the advanced directive with the signature and all the information that's in it. So we should, really try to integrate some of this into the nursing curriculum and the nursing program, just like medical schools are starting to do it with their programs. So this could align in the same way. And, having ALNEC, the modules and the courses that have become, fairly easy to integrate into the curriculum, different methods of that. Again, that is part of all of that training that can really be beneficial, not only for introducing palliative care, but in all aspects of nursing, palliative care is a part of it. So even, when it comes to pediatrics, when it comes to labor and delivery, when it comes to mental or behavioral health, all of those, aspects will have a palliative care, patient involved at some point or another. So it's one of those things that this whole topic can be really beneficial for all aspects of the nursing curriculum, and not just its own standalone, which is where it is mostly right now. It's mostly, it's standalone or with ethics but having, different modalities of teaching it, such as simulation and communication, or simulation with them doing hands-on things, or, pairing it with some of the modules from ALNEC can be really great, to have it throughout their learning. Just like with this particular one with the nursing students, we were able to do an unfolding scenario between the 3rd and 4th years. So that's also another benefit from adapting an existing simulation that's out there and also integrating it into the curriculum to meet the competencies for AACN. And I think, the other really great aspect of this work that we did as a team was that we were able to meld both a university and a health system together to try to come up with the best way to implement this simulation. And everyone worked very well together in the sense that once it was adapted for the pre-licensure students, that same approach was talked through for the nurse residency program, and then it was implemented there. So it does give a good bridge over from the hands-on approach, so that whatever the nurses are learning in the curriculum actually is applicable in real life. And we have both perspectives of that from the nurses that are practicing and also those that are in school. Next slide, please. So that's what we have for our presentation. We're open to any questions, and the next couple of slides that are in here are references. So those go on and on, but we're open to any questions.
Thank you so much for that. Can I start with a question?
Yeah.
Yeah, so I really appreciate that you mentioned that the simulation is in the faculty corner, and we can talk about that, where folks might find those resources later. And also those of you that are on the call or in the webinar, I should say, that may have another exemplary kind of simulation. If you want to share that, you can see a link to submit that through the website to go on to the faculty corner as well, because to your point, let's not keep reinventing the wheel. Let's take what people have done, that they've done a really nice job creating, and adapt it in our own settings. So my question is, I love the collaboration that you had between the academic setting and clinical partners. And it sort of sounded like, even though I'm pretty sure I hear you, that it's not the same cohort of people. Like you have your students that are getting a particular scenario or simulation, and then something quite similar happens with residency folks, maybe 10 months into their, quite a bit later. And it sounded like one thing, even though, again, I know they're not the same people, but it sort of sounded like the comfort around advanced care planning kind of things got better. There was at least greater familiarity with in the nurse residency, the novice nurses that were in that program later on, which is really interesting. And do you give each other kind of feedback about that, so the academic, units can help work towards practice-ready students a little bit more, what you're seeing on the clinical side and that kind of thing? Just curious.
We do hold advisory board, like many of the universities hold an advisory board, or they hold like a yearly meeting for a lot of their CCNE accreditations for feedback. And these are a lot of the things that we do feed back. At the time when I worked at the organization and was the residency program coordinator, I would tell them all the things that we were doing to try to, because it's one thing to expose them in practice, but to get it beforehand, it's another reinforcement. So the more you can do this, and the more it even starts in their undergraduate experience, like that's where you start building, because
Right.
once you experience it once, then they start to notice it a little bit more. I would say that if we had done this for years and years and years, we probably would have seen UConn students, because it is in Connecticut and UConn is in Connecticut. We probably would have seen the students who had done it then repeat it in our residency program, because we did hire lots of UConn graduates. But we didn't have that problem because it was all happening simultaneously while this was actually happening. So I think that would have been a benefit. But one of the things we did talk about was just exposing them over and over and over again, because it's all about comfort. really, and having those being aware of and noticing the things and when you actually do need to have these conversations. And I think that going to the University of Connecticut now, I'm able to share my experiences with them so that they can validate that this is an actual thing that is overwhelming for them.
Yeah. And I don't think there's anything that any of us could say we've done one time and feel ready to roll, especially when it's, tender, difficult things like this. I have one other sort of comment, and then I'm going to give it back to Dr. Lippy. I really appreciate that it sounds like the students became more aware of the difference between hospice and palliative care, and that you had some great resources for them to be exposed to. But I also would challenge all of us to be thinking about how we can take these ideas and apply them in different settings, because those folks with serious illness really exist everywhere. And one of you mentioned labor and delivery, or something where they're going to still see that kind of thing in a variety of different settings. So we need to help kind of re-envision the places where we might expose students to all of these things.
Yeah,
Thank you
and
so much.
yeah, thank you. I think the nurse residency program is great too, because all the students are in various units, so they do all get exposure to it. And what I noticed with the residency, the nurses, is that they, although they were, 9-10 months in, they definitely had more confidence. And I think when they, read the pre-work, they recognized all these patients that they've taken care of that, could have used a conversation or were eligible for palliative care. So I think, them being in practice, kind of opened up their eyes to, like, it's a lot of patients I'm sure they're taking care of. So yeah.
So I have one thought. I mean, I have lots of thoughts. I think this is first an exemplar of a beautiful academic practice partnership. And so I think this could be a real cornerstone for some other schools to think about, that it really is that exchange across institutions to generate practice ready nurses. One of the thoughts that came to me though is that sometimes we'll hear people say, well, I had an advanced care planning conversation, so check, I'm done, right? That it's a one and done. But that's not the reality with serious illness, that as their illness progresses, they get to later stages and their goals might change, their preferences change. And so making sure advanced care, those documents are updated accordingly and those conversations are ongoing. So I could see even having this 2-time interaction with a patient, I would suspect the conversation was different, or the patient was in a different, you mentioned patient was in a different place in their illness. So I could see even part of being that their goals have changed. And how does that make them realize, oh, this is not a one and done. Advanced care planning is a journey, just like serious illness is a journey. So I think that's a real strength of the unfolding element. There is a question in the chat. Was there any worksheets or questions that you gave the students with the Whitehead article to help discuss?
Yes. So we had about 4 questions that they had to answer for their pre-work. Actually, did they just read the article? They might have just read the article for the pre-work, and then we asked these questions. But it was basically, what is their understanding of advanced care planning, advanced directives, code status, goals of care conversations. So those were just, it was more about nursing interventions within in that article, but we really wanted to focus just to make sure they had a baseline understanding, because when the original simulation happened and the results came back for the outcomes for the novice nurses, we had a couple of nurses that were within their first 1 or 2 years. That knowledge was one of the deficits about actually understanding what it all was. So we wanted to make sure they actually had that baseline before going into the simulation.
Any other questions for our panel of speakers?
I just have a comment that has gotten me thinking about this, what sounds like a really rich source of data from the Vizient folks that have been looking at this stuff with new grads. And, we're always, as you mentioned early on in the presentation, that students feel like they don't have this. They probably have a really pretty solid current pulse on that if they've been collecting that kind of data for 20 years. And I'm just so curious if they share that back with academia, because that could be really useful information for schools.
Our articles are all over the place. I mean, I don't know if there's anything specifically written about end of life, but you can see a lot of their data over the years written up in articles. I mean, they're referenced everywhere. But
I'll be looking for that.
it's
with-
really it really is amazing. And I mean, you have to belong to see the data, but it trends you. It deals with a lot of other things like communication and leadership and time management and prioritization, but it all goes together, and then it benchmarks you against all of these other 30,000 graduates that are going through the program at that point in time. But it's a wealth. It's almost too much information,
Yeah.
I'll say. So.
Thank you. There's another question here, or comment maybe. Pam, do you want to share?
We do a scenario that evolves across the semester, sort of. Well, we have a patient that evolves across the semester. And when the students first meet him, they have a story, what's wrong with them. They're doing things like figuring out how would palliative care benefit this patient and how could it be useful. Later on, they meet him, they interview him. He's estranged from his daughter, he's widowed. So they get to experience, here's a patient who does not have that Leave It to Beaver family unit at home to support him and how they can help him. And they even get him to make contact with his daughter again, usually. It's up to them, but the groups usually do. And even, what was really important to him is he has a dog that he's really worried about. So there's usually a group that will, want to make sure that his dog is taken care of so that he can feel secure. And as the semester progresses, he'll update him with the phone call. He does a little video for him. And at the end of the semester, they get to experience his passing. And then, how to deal with each other, the staff as well as his family.
Thank you.
It's fantastic. Well, as we're coming to the end here, I just want to thank our panel again for sharing this incredible work that they've been doing. As mentioned, this sim is on our LNEC faculty corner, and I provided the link in the chat, so encourage you to check that out. And there's a host of other ones as well. But before we end, we do want to share a few upcoming events that you might want to put on your calendar. So I'm going to turn over to Dr. Davis. But again, thank you to our panel so very much for sharing with us today.
Yes, and I commend all of you for being here at the end of a busy time of year for folks. So hopefully you see on the screen, if you're interested in collaborating with other faculty around how you might integrate palliative care education into your curriculum, we're excited to share this second faculty development and leadership in palliative care workshop that is grant funded. So it will be here on my campus at the University of Portland in Oregon, July 24th and 25th. There's a link at the bottom here. You can just Google Faculty Corner LNEC, and this page is going to come right up. But you'll get to this page, and then down here is the upcoming workshop, which this is what that is. And who should apply? Anybody that is teaching in undergraduate or graduate education. That's a difference this year. We're taking faculty that teach in the graduate programs as well. 2 people from each school can apply. And the grant covers food for 2 days, housing. Yes, it's the dorms, but it's a lot of fun, and food. And you just need to get yourself here, and registration. So we have really a wonderful teaching team this year, and we're really so excited to be able to offer it again. So any of you interested, applications are staying open until May 15th.
May 16th, I think we're going to do
16th.
Friday,
Okay.
but yes.
Okay.
The press, we still have spots, and we want all of them filled. So we are extending our application deadline to May 16th at 5 p.m. Pacific time. I do see some names in the list of individuals who I believe are attending, just because we are
Oh.
living in the list of attendees very frequently. So excited to see some names that we'll get to see more this summer. But please know, again, there are still spots in both tracks. Cost is basically travel and dinners. So, we cover a lot of those costs. There's also an opportunity to submit an abstract related to the work you're doing in palliative care. It can be completed or planned. And so if you need to have a dissemination opportunity to secure school funds for travel, put in an abstract. We've never said no to an abstract. We just want to make things possible for faculty to come and share what they're doing. So if you are already on our list to attend and you want to submit an abstract, to do that. And if you aren't coming, consider applying, because we do have an extension.
Well, with that, everyone, thank you so much for being here. Have a wonderful summer. We do have one more webinar on May 15th. And that is also found right here on the page. The impact of an LNEC online curriculum. Is that the right one? Yeah. On undergraduate nursing students' confidence. So back somewhat related to what we're talking about now. And that'll be May 15th.
Thank you.
Early in the morning. Thank you, everybody.
Thank you.